Today, I'm going to talk to you on pulmonary function tests and one of the pulmonary attendings over here. And the learning objectives for today's talk is to identify the indications for pulmonary function testing, apply Z-scores. Z-scores account for age, height, and sex and ethnic background to sort of make this uniform in terms of identifying abnormalities in pulmonary function testing, interpret spirometry results before and after bronchodilator administration, which every internist should know because you use this in your practice. Analyze and interpret flow volume loop patterns, which may be asked sometimes on your boards. Understand hypoxemia altitude simulation test, which is a test which we commonly prescribe for those who are taking a flight to see if they need oxygen on the flight. And how do you analyze a patient with shortness of breath and who presents with dyspnea, their pulmonary function tests, and what is the approach that you follow?
Excuse me, Dr. We can see the presentation.
It should be good now. Are you able to see?
Yes, we can see it now.
Are you okay? Yeah. So the main types of pulmonary function tests are spirometry, before and after bronchodilators and with exercise, lung volumes, which can be detected through gas dilution or plethysmography, which you don't need to know, diffusion capacity of carbon monoxide, the maximum inspiratory pressure, which determines the strength of your lungs, your ability to breathe in, and your lung capacity, your maximum expiratory pressure, which determines your ability to cough up secretions, the flow volume loops, which we will go into, exercise testing. If your pulmonary function tests are normal and you still don't have a cause as to why someone is short of breath, you do cardiopulmonary exercise testing where you simultaneously exercise an individual while monitoring their cardiac and pulmonary reserve, and bronchoprovocation challenge, which is one of the gold standards in detecting an individual with normal spirometry whom you suspect with asthma in detecting asthma. Here is an example of a full pulmonary function test report. On the top, you see spirometry. You look at the FEV1 FVC ratios. You look at the FEV1 and the FVC. On the slow vital capacity, below that, the lung volumes, total lung capacity, and then the diffusion capacity. These are lung volumes and capacity, which you all have known in your physiology. The tidal volume is the air that you breathe in and out. The maximum inspiratory reserve is the sum of the tidal volume plus your maximum inspiration beyond your tidal volume. The vital capacity is the sum of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. And the expiratory reserve volume is the volume of air that is after a maximal expiration. And then the residual volume is the air after a forced expiration, is the air that is left in your lungs. This similarly describes the same thing that I said earlier. So what are some of the indications for pulmonary function tests? For individuals whom you suspect to have asthma or cough variant asthma, or patients presenting with respiratory symptoms such as cough, phlegm production, or unexplained dyspnea. Preoperative risk stratification in lung conditions for lobectomy or pneumonectomy, in heart conditions for CABG or for valvular surgery, and then, of course, in organ transplantation, either heart or lung, and in abdominal surgery. We risk stratify these patients to see how well can they tolerate anesthesia and what is their risk for pulmonary complications post-anesthesia. You also help in monitoring severity and disease progression. In individuals with known history of sarcoidosis or interstitial lung disease or COPD, you follow up their pulmonary function tests on a 6-monthly basis to see how well they are doing, responding to therapy or progressing. In heart conditions such as CHF and pulmonary hypertension on a yearly basis. And in neuromuscular conditions, you monitor patients' PFTs in order to determine what is the right time to place these patients on non-invasive ventilation and, if progressive, tracheostomy. And also for disability and impairment evaluation, legal and insurance evaluations, and social security compensation programs. Some of the contraindications to doing a spirometry, obviously, is pneumothorax. You do not want them to blow out against resistance in an individual who has a collapsed lung. In an individual who is coughing up blood actively, recent MI or unstable angina within the first 4 weeks, recent thoracic or abdominal surgery because you'll aggravate their recent recovery from their surgery, recent eye surgery because it can raise your intraocular pressure, thoracic aneurysm, and acute disorders which affect performance. Obviously, nausea, vomiting, or vertigo. They are not able to blow into a closed mouthpiece because that will trigger off their nausea. You hold bronchodilators as short-acting beta agonists, albuterol, levoalbuterol for 4 to 6 hours. The antimuscarinic agents, short-acting ipratropium for 12 hours, the long-acting beta agonists for 24 hours, and the long-acting long-acting muscarinic agents for 36 to 48 hours. Spirometry, which you should all know, is the most useful pulmonary function test, which measures the airflow during a forced complete exhalation after maximal inhalation. The FEV1 FVC ratio is the key ratio which you should know. You look at that ratio. You also measure their forced expiratory volume, which is the volume of air exhaled in the first second after a forced maneuver, and the forced vital capacity, which is the total volume of air exhaled during the complete forced maneuver. The slow vital capacity is also used to confirm that the forced vital capacity on spirometry is a true reduction and not related to bronchospasm. The SVC helps in distinguishing whether coexisting restriction is also present. Remember, if both the slow vital capacity and the forced vital capacity are reduced, this suggests coexisting restriction. So usefulness of spirometry. Yes, in asthma and COPD, it's a key diagnostic test. All individuals who have a 20-pack tobacco use history must undergo screening PFTs to at least to monitor them for to make sure that they do not have early COPD, and starting treatment for them early would help in preventing the progression. In individuals with asthma, either for diagnosis or for managing their asthma, or for augmenting the therapy for those individuals who are poorly controlled. In the evaluation of chronic cough, whom you suspect that they might have asthma, and also for disease monitoring as it tracks progression of interstitial lung disease and neuromuscular disease. Talking about the Z-score, in the past, we used to use percentage of predicted. In this hospital, we use the Z-scores, which is the measured value minus the predicted value, divided by the standard deviation. It gives us a range of minus 1.645 to plus 1.645, which is in the normal range. Anything below minus 1.645 is considered abnormally low. Anything above 1.645 is considered abnormally high. So anything, as I said earlier, between minus 1.645 to plus 1.645 on the Z-score, which takes into account the age, the sex, the height, and the ethnicity of the person, And mild impairment is between minus 1.645 to minus 2.5. Minus 2.5 to 4 is moderately impaired, and less than minus 4 is severely impaired. Here is an example of a 50-year-old male with a forced expiratory volume of 2 liters with a z-score of minus 2. So minus 2 is below minus 1.645, but less than minus 2.5. So he is below the normal range, and this would put him in the mild asthma or COPD category. Example 2 of a 60-year-old female with a forced vital capacity of 3 liters with a normal z-score. So the FVC is in the normal range. So this is how you interpret spirometry. You look at their FEV1 FVC ratio. If that ratio is normal, if the FEV1 is normal and the FVC is normal, that is a normal spirometry. If the FEV1 FVC ratio is below the lower limit of normal, less than minus 1.645, and or the FEV1 is low, and the FVC is normal, that constitutes obstruction. The key thing in this equation, if the FEV1 FVC is below a lower limit of normal, and even if the FEV1 is low or normal, that constitutes obstruction. The third area is the FEV1 FVC is normal. The FEV1 is normal, but the FVC is below the lower limit of normal. That constitutes restriction. In the fourth example, FEV1 FVC is below the lower limit of normal, and the FVC is below lower limit of normal. Here you have the ratio, which is low. The FVC is also low. This constitutes both an obstruction and a restriction. Remember, if the FVC is ever low, you need to confirm this with a total lung capacity and measure lung volumes. And the last example is the FEV1 FVC is normal and the FEV1 is low and the FVC is normal. This is a non-specific pattern and it's probably related to obstruction, but needs to be monitored with time. For those individuals who are in those labs who are not able to get a z-score on their pulmonary function test, the percentage of predicted helps in identifying and categorizing these individuals as mild, moderate, severe, or very severe based on their percentage of predicted. If the FEV1 FVC is between 70 to 80% is mild, between 50 to 70% is moderate, 35 to 50% is severe, and less than 35% is very severe on spirometry. So spirometry post-bronchodilator response, it helps in determining the degree of bronchodilator responsiveness. How is this carried out? You perform a baseline spirometry, and then you administer albuterol via a multi-dose inhaler and a spacer or through a nebulizer. You repeat the spirometry 15 minutes after the bronchodilator. If there is a change in the FEV1 or the FEV1 FVC ratio normalizes, that is highly suggestive of asthma. Okay, while if the response is greater than 10%, which I will go into a little later, it means that they have a positive bronchodilator response, which means that, and if the patient is suspected to have COPD, this could be a combined overlap syndrome of asthma COPD. So how does one interpret a positive bronchodilator response? In the past, they used to use a definition of greater than 12% and 200 ml. This has changed to a more consistent definition of greater than 10% increase in the FEV1 or the FVC. Remember that a lack of a bronchodilator response does not preclude a therapeutic trial of bronchodilators or inhaled steroids. In asthma, most bronchodilators often normalize spirometry, reverses to normal, which makes COPD less likely. How does one grade physiological impairment? The Z-score is preferred over percentage of predicted. As I said earlier, it accounts for age, sex, height, and ethnicity. It avoids demographic bias that percentage of predicted values introduced, especially in older adults. It also helps in determining physiological impairment. Remember, PFTs assess the degree of physiological impairment, not the clinical diagnosis. The severity of lung disease cannot be determined by PFTs alone. So this is some of the characteristic flow volume loops you see when you do a pulmonary function test. The graph on on A represents a normal. The upper axis is the expiratory limb of the flow volume loop, and below the axis is the inspiratory limb of the flow volume loop. In graph B, you can see a flattening of the inspiratory limb of the flow volume loop. When that happens, you suspect any issues with problems above and outside the thorax. Outside the thorax typically are the vocal cords and the larynx. So vocal cord paralysis, laryngomalacia can produce a variable extrathoracic airway obstruction. In graph C, you have obstruction in the expiratory limb of the flow volume loop, which is as a result of variable intrathoracic obstruction. Intrathoracic refers to what is in the chest. And so look at the trachea, look for tracheal tumors, but do not look for something which is completely occluding the trachea, but something which goes in and out, which means that there is partial occlusion, but not complete occlusion. In graph D, you have fixed upper airway obstruction in flattening of both the expiratory and the inspiratory limb of the flow volume loop. And an example of a disease which causes this is a large goiter which presses on your trachea. Supine and sitting spirometry is a great test that we do for diaphragmatic weakness. Normally, if you lay down flat, the lung function should not decline by more than 10%. A greater than 10% decrease in your vital capacity from upright to supine suggests diaphragmatic weakness. In unilateral diaphragmatic paralysis, there is a decrease of 15 to 25% when you lay supine. And in bilateral diaphragmatic paralysis, you can have a greater than 50% decrease in your vital capacity. How does one grade restriction based on percentage? This is for total lung capacity. Initially, I had talked to you on grading restriction based upon lung volume, based upon percentage on spirometry. This is for measuring their lung capacity. Mild is between a total lung capacity between 60 to 80%. Moderate is between 50 to 60%, and severe is less than 50%. So you also use lung volume interpretation. You use the Z-scores to categorize and measure their lung volume restriction. For those individuals who do not have Z-scores, you look at percentage of predicted. A Z-score of minus 1.645 suggests early restrictive lung physiology, and on the vital capacity, always confirm with lung volumes or total lung capacity if you suspect on your spirometry to have a reduced forced vital capacity. A mixed effect shows an FEV1, FVC, and total lung capacity, both below the 5th percentile, a Z-score less than minus 1.645. What this means is you on the spirometry, you have an FEV1, FVC ratio with a Z-score of minus 1.6, less than minus 1.645, and the forced vital capacity is low. And then you do lung volumes and the total lung capacity is also low. In this individual has a mixed effect of both obstruction and restriction. And an individual with air trapping, you can have a residual volume which is increased greater than plus 1.645. Maximum inspiratory pressure. This can explain unexplained decrease in somebody's vital capacity. And this is used to if you suspect respiratory muscle weakness. It is the maximum pressure produced while attempting to inhale through a blocked mouthpiece after full exhalation. Normal values for men is minus 100 centimeters of water and women is minus 70. And the lower limit of normal is two-thirds of these values. For the maximum expiratory pressure, it's the forced expiration through a blocked mouthpiece after full inhalation to total lung capacity. In men, it is 170 centimeters of water, and women 110, and the lower limit is two-thirds of these values. Why is this important? If you have a patient with myasthenia gravis on the floor, you ask the respiratory therapist to get the maximum inspiratory pressure. When the maximum inspiratory pressure, which I will tell you later, falls to a certain level, those patients belong in the ICU where they need to be monitored closely or they would need to be intubated. Respiratory muscle technique of doing these maneuvers of the maximum inspiratory or the expiratory pressures is it records it's a blowout for at least 2 seconds and records the largest pressure held for at least 1 second. You do 3 acceptable maneuvers and you take the highest of the 3 results. It can vary from test to test, and a pressure difference less than 25 centimeters of water is acceptable. Remember, a fall in the forced vital capacity from upright to supine position correlates with significant inspiratory muscle weakness. So if you ever suspect muscle weakness and you're not able to do a maximum inspiratory pressure, you could do the forced vital capacity while sitting up and while laying down. The respiratory muscle pressures clinical interpretation for what is considered as normal. A normal maximum inspiratory pressure results has a strong negative predictive value and is effectively rules out clinically significant inspiratory muscle weakness. If one has a low maximum inspiratory pressure, these individuals need to be monitored. What is the cutoff threshold for a low value? Anything below 1/3 of normal predicts hypercapnic respiratory failure. These patients belong in the intensive care unit. And for the maximum expiratory pressure, anything less than 60 centimeters of water pressure constitutes a low maximum expiratory pressure. And what does this signify? A weak cough and an inability to clear secretions. So if you see a patient and you do a maximum expiratory pressure, which is less than 60, these individuals may need additional support, such as with a cough assist device to help in percussing their lungs and helping them to clear their secretions. In monitoring myasthenia crisis, the 2030 rule, 20 ml per kilogram in the forced vital capacity falls below the threshold and is an indication for elective intubation. On the maximum inspiratory pressure, anything less than minus 25 to minus 30 should be considered for elective intubation. The diffusion capacity for carbon monoxide, it's the ability to exchange oxygen for carbon dioxide at the alveolar capillary surface. In restrictive lung disease, your diffusion capacity is reduced because of alveolar damage. While in obstructive disease, your diffusion capacity is reduced because of alveolar destruction. And the diffusion capacity in obstructive disease and COPD occurs in emphysema, but not in chronic bronchitis. So if you have findings consistent with COPD with normal diffusion capacity, these individuals probably have asthma/chronic bronchitis. While if you have a PFT consistent with COPD with a low diffusion capacity, these individuals have emphysema. And of course, if you have a pulmonary function test, which is completely normal with an isolated decrease in diffusion capacity, which is impaired gas exchange at the alveolar capillary interface, suspect pulmonary vascular disease, such as thromboembolic pulmonary disease or pulmonary arterial hypertension. Also of note, these individuals sometimes can have advanced COPD, wherein they have fairly normal lung function, but an isolated decrease in diffusion capacity. How does one categorize diffusion capacity based on severity when the Z-scores are not available? Mild impairment is between 61 to 75% of predicted, moderate being between 41 to 60%, and severe less than 40%. There are physiological variables in your pulmonary function test as one gets older. With regards age, during childhood, your lung function rises linearly with growth. After the age of 35, your FEV1 declines by 20 to 30 ml per year. This is not considered significant in individuals who are normal, that is, who have not smoked and who do not have interstitial lung disease or who do not have COPD. But this is extremely important for individuals with advanced lung disease. Losing 30 ml of lung function every year is detrimental to their lung health. The residual volume increases as one gets older. The total lung capacity stays intact. Also, the diffusion capacity declines linearly throughout adulthood. Taller individuals have larger lung volumes, have higher maximum flow rates, and higher diffusion capacity. Height is the strongest single anthropometric predictor of lung function. And that's the reason why we use Z-scores to account for age, sex, height simultaneously while getting what the normal should be. Males have larger lung volumes and higher flow rates than females of the same age and height. And as I said earlier, Z-scores account for this sex difference. Most consistent finding in obesity and weight gain is a decrease in their functional residual capacity and a decrease in your expiratory reserve volume, especially if an individual has a BMI of greater than 30 kilograms per meter squared. The effect on spirometry is small, and the FEV1 FVC ratio is usually preserved. So weight decreases your FRC, functional residual capacity, and your expiratory reserve volume. So this is a step-by-step approach to evaluate dyspnea with spirometry. So on the light green, if you have on spirometry a low FEV1 FVC ratio and a normal FVC, that constitutes obstruction. Once you diagnose obstruction, you see what their response to a bronchodilator is. If the FEV1 is unchanged, this is more likely COPD. If the FEV1 improves by 10% and the obstruction normalizes, this is most in keeping with bronchial asthma. You then look at the diffusion capacity. If the diffusion capacity is normal or high, this is consistent with asthma and chronic bronchitis. If the diffusion capacity is low, this is COPD, emphysematous kind. If the spirometry in the middle column is normal and your symptoms is highly suggestive of asthma, you do a bronchoprovocation challenge test with methacholine. If there is a significant decline in your FEV1, which is a 20% reduction in your FEV1 on methacholine challenge, asthma is a most likely diagnosis. If there is no change on the methacholine, asthma is not likely as the cause of the individual's shortness of breath. On the right-hand side, if the spirometry is normal, look at the diffusion capacity. If the diffusion capacity is normal, the patient has normal lung function. However, if the diffusion capacity is low, then possibilities include early interstitial lung disease or pulmonary vascular disease. On the last column in light purple, if you have a normal FEV1 FVC ratio and a low vital capacity, suggests restriction. You always need to confirm restriction with lung volumes, and that is through a total lung capacity. If the total lung capacity is low, that does confirm restriction. You also look at the diffusion capacity. If the diffusion capacity is low, which occurs with parenchymal lung disease, its most likely diagnosis is interstitial lung disease, while if the diffusion capacity is low, it suggests normal, it suggests chest wall or neuromuscular disease. If you suspect neuromuscular disease as the cause of the patient's restriction, you do their maximum inspiratory and expiratory pressures to look at their muscle strength as the contributing factor in their neuromuscular disease. Some of the other tests we do in pulmonary function test is a 6-minute walk test, is a good index of physical function and therapeutic response. We do this in our office, in our pulmonary office, with all individuals with COPD when they come back here for follow-up in 3 months, in patients with pulmonary fibrosis and interstitial lung disease. You want to see their outcome of the treatments that have been recommended to them. Healthy adults walk between 400 to 700 meters, and the magnitude of desaturation and heart rate recovery helps in knowing their progress. A pulse oximetry is important. You check the saturations. This is very important for you all to know, and this will be asked in your boards. A saturation of less than or equal to 88% constitutes a need for supplemental oxygen. And this can occur either at rest or with ambulation or with sleep. When you prescribe oxygen or for patients who are discharged, you need to specify the oxygen. Number one, how is it being delivered? Through a nasal cannula or through a mask. Number two, is the oxygen and the quantity of oxygen that you prescribe, is it at rest, with ambulation, and with sleep? Because all those three numbers can vary. For example, if a patient is hypoxic at rest, with ambulation, it drops further. So he might require 2 liters at rest. He might probably require even more oxygen when he is ambulating. And for those individuals, it's important to do an overnight pulse oximetry study, either on or without oxygen, to determine if that individual drops on the oxygen that you're providing so that you can give him a right prescription to use oxygen when he sleeps at night. For those individuals with saturations of less than or equal to 89%, but who have these three conditions, either of these three conditions, cor pulmonale, right heart failure, or a hematocrit greater than 55%, they qualify for supplemental oxygen. An arterial blood gas is an adjunct to PFTs in selected patients. It can help you confirm hypercapnic respiratory muscle weakness, advanced COPD. One of the pointers to trying to evaluate a patient with obesity hypoventilation is a bicarbonate on your BMP of greater than 27 in an individual with a BMI of greater than 30. Such individuals, if you suspect obesity hypoventilation, get an arterial blood gas. And these individuals with PCO2 greater than 45, BMI greater than 30 may qualify for CPAP on discharge or BiPAP if they are intolerant to CPAP. Cardiopulmonary exercise testing is a graded exercise which includes your cardiac, pulmonary, and metabolic responses to identify the limiting system in individuals who have persistent shortness of breath and in individuals in whom lung function and imaging do not give you a diagnosis as to their etiology of shortness of breath. Indications include unexplained dyspnea when PFTs and imaging are inconclusive, disproportionate activity limitation, to identify and differentiate cardiac versus respiratory causes of shortness of breath. It's a great tool with disability and impairment assessment. It objectively and determines your functional capacity. It's important in preoperative risk assessment, especially for high risk or complex surgery when PFTs are not completely clear whether an individual can tolerate major surgery. And in transplant, in lung and cardiac transplant, we do this routinely. Hypoxia altitude simulation test. This is to check for oxygen and to provide patients with an oxygen prescription for those who are flying. For those individuals with a saturation greater than 95%, on room air do not need to be tested. For those individuals with saturations between 92 to 95%, but who have comorbidities like COPD or heart disease, consider testing. For those individuals who are going to be flying with saturations on room air which are less than 92%, I recommend that they undergo this test. We do have this in our hospital here. How this is done is they inspire gas, 15.1% oxygen via a well-fitted mask for 20 minutes. If their saturations go less than 85%, they qualify for oxygen. So for individuals with chronic dyspnea or who presents with exertional dyspnea, always get pulmonary function tests. And if the diagnosis is clear, manage according to their diagnosis of obstructive or restrictive lung physiology. For those individuals, as I said earlier, who are inconclusive, you do a cardiopulmonary exercise testing. In asthma, it's important that you do pre and post bronchodilator spirometry. Every individual with asthma whom you diagnose in the hospital should go home with a peak flow. They need to monitor their peak flows. And whenever they are in the red zone, they need to seek help or go to their primary care physician. And if they are in their low yellow zone or high yellow zone, they need to confer with their primary physician. The PFTs also help in determining conditions such as cough, whom you suspect to have asthma, in identifying bronchial hyperresponsiveness, and in also determining pre and post bronchodilator spirometry, especially in individuals who are symptomatic. And for those individuals who have normal spirometry and who you strongly suspect to have asthma, do a bronchoprovocation challenge testing with methacholine. A positive test is a decrease in the FEV1 by greater than 20%. In COPD, pulmonary function tests are useful in determining the severity of their lung disease. The lung volumes are important in determining hyperinflation. Increase in residual volume and functional residual capacity also helps you in telling if they have coexisting gas trapping. It helps in tracking disease progression. Here are the examples of flow volume loop, which I talked to you earlier. In intrathoracic fixed airway obstruction, where there is flattening of both the inspiratory and the expiratory limb, common causes include airway stricture or goiter compressing the trachea. In variable intrathoracic, in variable, where the expiratory limb of the flow volume loop is affected, in variable intrathoracic airway obstruction, these examples are tracheomalacia and tracheal tumors. In fixed extrathoracic airway obstruction, where both the inspiratory and the expiratory limb are flattened, some examples of this include bilateral vocal cord fixation and rigid tracheal stenosis. And in variable extrathoracic airway obstruction, where there is inspiratory limb is flattened, it happens in vocal cord paralysis and in laryngomalacia. We went through this earlier. In restrictive lung disease, you look at the diffusion capacity. If the diffusion capacity is reduced, it suggests interstitial lung disease as the cause of the restriction. In individuals with restrictive lung disease with a decreased total lung capacity, you look at the diffusion capacity, and if the diffusion capacity corrects for alveolar volume, it means that they have a disease outside the interstitium causing their restriction, such as chest wall or pleural disease. And in individuals with neuromuscular disease where you have restriction, their diffusion capacity is usually normal, and the FVC will fall when they lay supine. In individuals, as I said earlier, who are obese, their FRC and the expiratory reserve volume is reduced, especially for BMIs greater than 30 kilograms per meter squared. In pulmonary vascular disease, here you have a lack of diffusion between the alveolus and the capillary which surrounds that. Their spirometry is near normal. Their total lung capacities are near normal. You suspect this classically in thromboembolic disease and in individuals with pulmonary arterial hypertension. Preoperative PFT testing. When spirometry is indicated, especially in individuals with you suspect COPD or asthma, current or recent smokers, those who are undergoing thoracic or upper abdominal surgery, and who are high-risk surgical candidates. For those individuals who have borderline PFTs and whom we are not sure that they should go for surgery, one can optimize their lung function through prophylactic pulmonary hygiene, smoking cessation, bronchodilators, short course of steroids, antibiotics for bronchitis, and then repeating their spirometry and then clearing them for surgery after optimizing their lung function. In lung resection, PFTs are useful. You start with spirometry and diffusion capacity. If either of these are less than 80% of predicted, further testing is required through quantitative perfusion scans and cardiopulmonary exercise testing. It's also great in disability evaluation. Resting values have limited value. Sometimes cardiopulmonary exercise testing is needed, especially for disability evaluation. From here, I'm going to go over 4 cases of normal spirometry so that y'all can master spirometry as well as lung function. And if time permits, I will go over obstructive and restrictive lung physiology as well. So this is a normal spirometry. You look at the FEV1 FVC ratio. In this case, you have an FEV1 FVC ratio of 82%, a z-score of minus 0.32, which is between minus 1.645 and plus 1.645. You then look at the FEV1, which is 3.28 liters, which is 97% of predicted, which is normal, and the FVC, which is 4 liters, which is 98% of predicted. So you have a normal FEV1 FVC ratio, a normal FEV1, and a normal FVC. So this is a normal spirometry. What was the post-bronchodilator response on the FEV1? 4%. It fell below the threshold of 10%. So there is no bronchodilator response in this individual. If you want to go a little advanced, look at the total lung capacity, 5.56 liters, which was 103% of predicted, which was normal. The diffusion capacity, 21.99%, which was 95% of predicted, which was also normal. So summarizing, normal FEV1 ratio, normal spirometry, normal total lung capacity, normal diffusion capacity, and no bronchodilator response. We'll go to case number 2. Looking at the FEV1 FVC ratio, 83% of predicted, which is normal. You look at the FEV1, 3.69 liters, which is 90% of predicted. If you go by ratio, there's no z-score here. If you look at the FVC, 4.42 liters, which is 91% of predicted. Normal ratio, normal FEV1, normal FVC. This individual has normal spirometry. Look at the bronchodilator response, plus 8%. Not significant, not greater than 10%, not considered a positive bronchodilator response. Look at the total lung capacity, above 80% of predicted, which is at 91%, which is normal total lung capacity. Look at the diffusion capacity, 92% of predicted is normal. So normal spirometry, normal total lung capacity, normal diffusion capacity without significant bronchodilator response. Case number 3, FEV1 FVC ratio, z-score of plus 0.59, which is between minus 1.645 and plus 1.645, and 80% of predicted, which is normal. You look at the FEV1, 2.99 liters, 92% of predicted, which is normal. Look at the FVC, 3.73 liters, which is 86% of predicted, which is very mildly reduced. Okay, it does not mean anything because the FVC always needs to be confirmed by a total lung capacity. So this is considered a normal spirometry. The total lung capacity is 86% of predicted, which was normal, and the diffusion capacity 81% of predicted, above 80%, which is normal. Summarizing, normal spirometry and normal total lung capacity and normal diffusion capacity. Case 4, normal spirometry, again, FEV1 FVC ratio of 77%, above 70%, which is normal, and the z-score shows that minus 0.37. Look at the FEV1, 4.10 liters, 93% of predicted. The FVC, 5.29 liters, 96% of predicted. So essentially normal spirometry. Look at the bronchodilator response. On the last column, 7% changed, less than the 10% change, so no bronchodilator response. Look at the total lung capacity, 101% of predicted, normal, diffusion capacity, normal. So normal spirometry, no bronchodilator response, normal total lung capacity, and normal diffusion capacity. Am I going too fast? Now I'm going to talk about 4 cases on obstruction, okay? Look at the FEV1 FVC ratio, less than 70% of predicted, 69% here. What is the rate? What is the z-score? Less than minus 1.645, which is minus 1.97. So FEV1 FEC ratio, which is low, is consistent with obstruction. So it does not matter if the FEV1 is also low, but it helps in confirming obstruction. Okay, so the FEV1 in this case is normal at 99% of predicted. The FVC is normal. So you have a low ratio. A low ratio is suggestive of early and mild obstruction. Okay, the total lung capacity was normal. The diffusion capacity was normal. So remember this, FEV1 FVC ratio low, consistent with obstruction, despite the fact that the FEV1 was normal and the FVC was normal. Second example, FEV1 FVC ratio is below 70% of predicted. It's at 65%. Look at the FEV1, 1.71 liters, which is low and 61% of predicted. If you look at the z-score, minus 1.65 to plus 1.65, it is, and minus 1.65 to minus 2.5 is considered moderate. So minus 2.76 is moderate reduction in your FEV1. Look at the FVC, which is low normal. Look at the total lung capacity, which is within range, which says it's normal, and the diffusion capacity was reduced. So in this example, you have moderate obstruction because the FEV1 FEC ratio is low. The FEV1 shows moderate reduction in their FEV1. There is no hyperinflation where the total lung capacity is increased. The diffusion capacity is low. So in this example, in an individual which suggests obstruction with a low diffusion capacity, this is a classical example of an emphysematous individual with COPD, where you have a low diffusion capacity. Remember, I said earlier, chronic bronchitis, the bronchial tubes are involved, while in emphysema, it is destruction of the alveoli. It is the alveolar gas exchange which causes a reduction in your diffusion capacity. Example 3. Look at the FEV1 FEC ratio, 54%, z-score of minus 3.61, severely reduced, moderately reduced. Look at the FEV1 ratio, 1.77, 46% of predicted, quite severely reduced. Look at the FVC, 3.28 liters, mildly reduced. Look at the FEV1 change, plus 35% of predicted, plus 35% change in the FEV1 post-bronchodilator response. FVC also responds by greater than 30%, so greater than 10% change, and normalization of your obstruction is classical for asthma. The diffusion capacity is normal in this instance. So severe obstruction with dramatic bronchodilator reversibility with near normalization of spirometry post-bronchodilator response favors asthma over COPD. And here's the fourth example of severe obstruction. You look at the FEV1 FVC ratio, which is 51% of predicted, which is severely reduced, consists with severe obstruction. The FEV1 is 0.85 liters, 48% of predicted, minus 2.84 on the z-score, which is moderate obstruction. You look at their residual volume to total lung capacity, which is markedly elevated with a z-score of plus 4.17, which suggests severe trapping. If the total lung capacity on your obstruction is elevated, it suggests hyperinflation. If the residual volume is increased, it suggests gas trapping. Okay, so there is hyperinflation, there is gas trapping, there is severe reduction in your lung function. This picture this picture is consistent with severe emphysema, in fact, advanced emphysema. The diffusion capacity is also severely reduced, greater than less than minus 4, minus 4.81, which is severe reduction in your diffusion capacity with spirometry consistent with severe COPD. Now, restriction pattern. You look at the FEV1 FEC ratio is normal. You look at the FEV1, which is low. It does not matter if your ratio is normal and the FEV1 is normal or low. It does not, you still will want to look at the FVC. Look at the FVC, which is 1.72 liters, which is 59% of predicted, which is low. So that constitutes mild to moderate restriction. It is important if you suspect on spirometry a reduction in your forced vital capacity to get total lung capacity, which is also moderately reduced with a z-score of minus 3.80. You look at the diffusion capacity, which is normal. So an individual which shows moderate restriction, which is confirmed on total lung capacity, with a normal diffusion capacity, suggests a chest wall etiology as to their shortness of breath, or an extrinsic etiology such as pleural disease or chest wall deformity or neuromuscular disease. Example 2, look at the ratio of FEV1 FEC, which is normal. You look at their FEV1, which is normal, the FEC, which is shows very mild restriction. On their total lung capacity, it shows 3.91 liters, which shows mild restriction with a z-score of minus 1.86 and a diffusion capacity of minus 5.15, which shows severe reduction in your diffusion capacity. So this individual shows mild restriction with a severe disproportionate reduction in his diffusion capacity, suggests strong evidence of advanced interstitial lung disease contributing to his restriction and impaired gas exchange. Case 3 of severe restriction, a normal ratio of FEV1 FEC, FEV1, which is 1.64 liters, which is 56% of predicted. You look, if your ratio is normal, always go straight to the FVC. The FVC is moderately reduced. If the FVC is moderately reduced, look at the total lung capacity. The total lung capacity shows severe reduction in your total lung capacity, so severe decrease in lung volumes. Look at the diffusion capacity, also severely reduced. This pattern of severe restriction, which is confirmed on total lung capacity, and severe decreased diffusion capacity, is consistent with advanced pulmonary fibrosis or interstitial lung disease. Case 4, look at the ratio, FEV1 FVC ratio, which is normal. The FEV1 is low normal, and the FVC is low at 70% of predicted. Look at the total lung capacity, which is moderately reduced with a z-score of minus 3.56. The diffusion capacity is minus 1.84, which is mildly reduced. This pattern is more consistent with moderate restriction, chest wall restriction, or parenchymal disease, and warrants further evaluation for neuromuscular or chest wall disease. Isolated decrease in diffusion capacity. Looking at case 1, you look at the FEV1 FVC ratio, which is normal. The FEV1 is normal. The FVC is normal. Look at the total lung capacity, which is normal. So you have an individual with essentially normal pulmonary function test, except that the diffusion capacity is severely reduced. So if you have an individual who presents with shortness of breath and on PFTs have an isolated severe decreased diffusion capacity, you do a CT angiogram which rules out pulmonary embolism, suggests pulmonary vascular disease as a contributing factor in his isolated reduced diffusion capacity. Case 2 is an individual with a normal FEV1 FVC ratio, a slightly decreased FVC, a total lung capacity which shows moderate restriction, and severe decrease in his diffusion capacity. This pattern suggests intrinsic lung damage, alveolar damage contributing to the patient's restriction and severe decreased diffusion capacity. In case 3, you have normal spirometry. You have an FEV1 FEC ratio, which shows obstruction, which is decreased at 64% of predicted at minus 2.28, with a normal FEV1 and a normal FVC, a total lung capacity which was normal, and a diffusion capacity which was mildly reduced. So you have mild obstruction on your spirometry with a disproportionately reduced DLCO. This is consistent with COPD, and of the COPD of chronic bronchitis emphysema, more consistent with emphysema because there is a reduction in your diffusion capacity. Then there are examples of borderline obstruction and severe reduced diffusion capacity, which I will end here for lack of time. I will be glad to field any questions. Yes.
So on the pulmonary function test, sometimes it says predicted value and measured or actual value, and they are different. which one do we use?
The measured value. The predicted value is what they should be for age, sex, height, and race. The measured value is what they actually are.
So we use the measure.
You use the measured value, and the z-score reflects the measured value in comparison to the predicted value.
We always want 80 to 90% for COPD if the SQ less than 80. Sometimes we want.
Yes, because in an individual with COPD, oxygen is like a drug. It slows down the decline of your lung function, and these individuals will tend to progress. So any individual with COPD, they need to be examined at rest to see if their saturation are less than 88%. You walk them, look at the desaturation. If they go below 88%, they qualify for oxygen. And of course, if they have polycythemia, erythrocytosis, or pulmonary hypertension, then value less than 89%.
We ever want them to be higher than 92 if they are descending.
No, 88 is a cutoff for oxygen. Anything above 88 is good. And you don't want them to be above 92 to 93 because it decreases their respiratory curve. Yes.
About the test what indicate for elective intubation and what kind of clinical situation can be referred for this test? Is there a clinical indication for intubation already can be, or decision made based on a study result? And additionally to this question, what gonna be extubation criteria for this kind of patient? Is there any additional study before extubation?
Yes. For those individuals who have done their ICU rotation, okay, and if you have an individual with myasthenia gravis, for example, you tell the respiratory therapist to get what we call as a NIF, a negative inspiratory force. When your negative inspiratory force falls below -30, that is an indication that the patient belongs to the ICU. In my clinical practice, in my experience, I've seen individuals with a value of -30, but who are clinically asymptomatic. But that is at least a guide for you to get a blood gas to see if they're starting to retain carbon dioxide. Yes, if they are starting to retain carbon dioxide with a negative inspiratory force of -30, or they are forced to vital capacity, which the respiratory therapist can do at the bedside, falls below the threshold that I outlined earlier, then they need to go into the unit to be observed. In terms of once they're intubated, what are the criteria used for extubation? You look at their tidal volumes, you look at their minute ventilation. For someone who produces tidal volumes of 150 to 200 cc's, you have the intensivist probably not even work towards extubating those individuals. They need to produce a decent minute volume of at least 6 liters at the very least. Normally, if you breathe in about 350 to 400 cc's multiplied by 20 is a good 8 to 10 liters of volume that you produce per minute. So 5 liters means that you're not adequately exchanging oxygen for carbon dioxide, and you have a propensity post-extubation to retain carbon dioxide. So you would be very careful. So unless their tidal volumes are great, only then would they consider extubating. For those whom you feel are pressure to extubate, you sometimes would, and you feel that they will do well, you can extubate them to non-invasive ventilation temporarily till their lungs continue to heal if you do not want to keep them on prolonged ventilation.
Thank you.